Hi everyone. Hi, Dr. Amin here. Happy Friday. Dr. Amin from Toronto. Another beautiful day. We're going live today with Dr. Jessica Shepherd to talk about women's health, menopause, perimenopause, hormones, and all those juicy stuff. If you hear me, please thumbs up. And as usual, if you have any questions, you can always drop it in the comment or the question bubble. So we try to go through those questions. Very good. Great. So you can hear me. Lovely. So I'm going to invite Dr. Jessica Shepherd to our live. Hi everyone. We wait another minute. Let me know where you are from today, where you're watching us today from, and what is your burning question? Let me know. I like to hear that. Hi everyone. We're waiting. Okay, let's see. I am just trying to invite. Hi. Hi from Toronto. I can see you, Dr. Jessica. I'm sending you invite. If you see it on top of your page, you can just accept. Let's see.
Hi.
Well, hi.
I feel like my camera is dirty. Oh my God. Give me a sec. How are you?
I'm good. How are you?
Good. I'm doing
Nice
really
to
well.
meet you.
Yes, you as well. And obviously we have the Toronto thing in. Do you see me just cleaning my camera? I'm like, I
Yes,
hate a dirty camera. Oh, here we go. That's better.
that's good.
Good to see you. How are
Lovely. And
you?
you.
Good. Thanks for jumping
So
on so quickly this morning.
great to see you.
Yeah.
And let's talk. Let's
Yeah.
talk
Go ahead.
about, yes, menopause and perimenopause. Despite the surge in in talk about
Mm-hmm.
menopause, and we see on social media led by celebrities, influencers, and even doctors, we still see many women, even healthcare professionals, when it comes to HRT, they're hesitant.
Yeah.
So
No, I think that
what
there's,
why do you think? Why are we
yeah,
still here?
yeah. Christy, hi. Hi. Hello from Dallas. I see you, Miss Dallasite. I'm here in Dallas too. So you're gonna have to come visit me. But no, I think just when we think of menopause, it really has surged in information sharing, community, especially. I think the community part of it is really impactful because women feel that they are not alone in the journey. And I think that now that they can find reassurance among other women, that helps them navigate the process, ask better questions. But as providers, we still have to do a better job, I guess you can say, at truly understanding menopause. And I think that's going to come through um, research. We have good research, but we need a little bit better research, or to further the research. I think that's a better way to say it. And then also really understanding how it's a whole body transition and not just someone has ovaries and their ovaries decrease estrogen. That's the physiologic part of it. But what happens when you have that decrease in estrogen is it impacts our heart, our brain, our bones, our gut, our muscles, and how our body functions. So when I, shameless plug, when I wrote Generation M,
Nice.
was to bring that all together because for so long, even as as a OBGYN, how we learned about menopause was really just focused on the pelvis and here are the ovaries and this is what happens to the ovaries. But when you really look at it dimensionally, there are so many different layers of it. And that's what I spend most of my time in my practice, when I'm on TV throughout the book, is bringing it all together. Because once you start to see that it is this collective of events that happen, then it actually makes it more understanding of why people feel the way that they do, or when women feel that they don't feel great inside, whether it's energy, whether it's libido, whether it's their mindset, is does have, or menopause or estrogen does play a factor into that.
Mm-hmm. Great. Yes. And so very commonly we see a lot of women during perimenopause. Now we're talking more about perimenopause. I
Hmm.
mean, this wasn't even a thing 4 or 5 years ago. So a lot of women we see misdiagnosed. So
Yeah.
what are some of those very surprising symptoms that can get misdiagnosed by doctors, or
Hmm.
how often?
Yeah, and
What do you?
I might change the term a little bit from misdiagnosis is to, as in like misdiagnosis as in wrong, is more of a missed, MISSED diagnosis of the oversight of that it could be due to perimenopause. Because the other part of that too is that no, now that more people are aware of what happens in perimenopause, the other part of that is we don't also want to miss things that it could be. So, for example, if someone does have a thyroid disorder, that may be contributing to their fatigue, may not just solely be a perimenopausal hormonal issue. And so, when we think of perimenopause, is really that time frame before getting to menopause. So, to me, to make it simple, is that the difference between perimenopause and menopause is that in menopause, you clinically do not have a period. And yeah, there are little differences, or there are differences between the hormonal shifts and how much estrogen is available. But when people come to me, they're very confused about what perimenopause is versus menopause. And the easy way I like to say it is you can have symptoms in perimenopause that are pretty much, identical to some of the symptoms you might have in menopause. But the one true difference between the two is that you do not have a period in menopause, and you do have a period, whether it's erratic, whether it's regular, whether it's irregular in perimenopause. So there is the function of the ovary still gives a period, but you can still have the symptoms of hot flashes, night sweats, mind fog, or brain fog, changes in your gut. I think you can start to see that you have decrease in energy, decrease in libido. Maybe your vaginal dryness might start to appear. So you start to see these subtle symptoms that may occur, but may also mirror some other issues that may be going on as well. So it really takes a really good step back from a provider and from a doctor standpoint to really rein it in and saying, okay, what's really going on, so that we can also address that and or something else. And they can also be occurring at the same time as well. So that's why this is such a very broad, complex part of women's health. And I think what we will start to see in, the next 5, 10, 15 years is really how to get doctors and healthcare providers to focus just on this transition of perimenopause into menopause,
Mhm.
because it really is so much that goes on, and I think we'd have to relearn what it is physiologically, but also looking at the outcomes when we think of heart health, brain health, gut health, muscle health. Is spotting a sign of perimenopause? So spotting, I'm going to rephrase what spotting is. It's not a sign of perimenopause, it's a sign that your estrogen is starting to decrease, and therefore the periods are a little bit irregular and may induce spotting. So it's kind of reverse. The estrogen decline is what may be causing the spotting. Now, if you haven't had a period for a year consecutively, no bleeding whatsoever, and then you start spotting, and you're not on hormone replacement therapy, then you should see your doctor, because you should not be bleeding after a year of no bleeding. So you clarified there between menses, yes. So your
Mhm.
ovaries start to have, I wish I had, I'm going to show you here if I can. Your ovaries start to kind of push out estrogen, not in the same regular fashion that it did when you were in your 20s, 30s, early 40s. And so that's why when it pushes it out without on the right, it's not like on a time schedule that it should be. That's why you might start to have spotting in between your periods, which would be I guess you can say if you want to, a sign of perimenopause, but it's more a sign of the estrogen decline rather than a sign of perimenopause. But that's just a nuance. So yes. Yeah,
So,
I was
so
just answering that question
yeah,
really quick. Yeah.
quite a bit of hormone imbalances during those years.
Yeah. Hmm. And so for people who are watching from Canada, I am Canadian.
Oh,
I've been in the
you're my
States.
second
Oh
Canadian
yeah?
and oh,
I
third.
oh
Yes, I
yeah.
didn't know. I wasn't aware of that.
Yeah. So I am born and raised in Canada, and then I moved here in my mid-teens and have been here since, but I'm very diehard Canadian, love being Canadian. Still have my Canadian passport. So yeah. So hello
Oh,
to all my fellow Canadians who are on here.
great. Lovely to know. And then what about we see a lot of metabolic dysfunction during this
Mhm.
time, or metabolic changes.
Yeah.
Why is that? Why women telling us all of a sudden we see this shift and change of fat around
Mhm.
our waist and chest?
Yeah. So there's again, when we think of the whole body experience of perimenopause into menopause, is estrogen really, there are receptors for estrogen. I'm from Toronto originally. Where are you
Ah,
from? From Toronto,
oh,
Scarborough.
ah.
um,
You should come
so,
here then. We
oh
will have a big
yeah.
talk soon.
Oh,
So hopefully, yeah, I'm going to
good.
invite you for sure.
um, no, so when we're talking about the metabolic change, is
Mm.
um, we might have some lovers of Canadian people. Don't look like Canadian people. Well, we are, and Canadian people look like everything, and everyone, and so thank you.
Oh.
And so the when we think of the changes metabolically, we basically start to see the whole body experience. There are estrogen receptors in the body, then it can start to sit. And when it sits and it's not utilized or metabolized, then that turns to fat. And so that's one of the components
Mhm.
of why you start to see that change in perimenopause and menopause. But also, our fat cells also take a hit in how they shrink and how they grow. And that's part of how fat cells function earlier in our life. They shrink and they grow. And eventually, when there's a decrease in estrogen, they change in the ability to obviously shrink, but they also migrate. So they move from the hip and the butt area into the abdominal area, which is why you start to see more of that
Mhm.
central kind of fat, which we call central adiposity. And that then leads to increase in how our heart functions, in and how our gut functions, and that, so it's like this cascade, everything is connected, and this is the cascade of what you start to see, that happens as estrogen starts to decrease. So estrogen and also progesterone and testosterone, I never want to leave those two out,
Mhm.
but estrogen really is kind of like the main hormone when we think of menopause and then also
Mhm.
women's health. And so that's why we start to see those changes. Here is a question: can estrogen decline affect fertility negatively, if you're in your late 30s? Well, that really is a biological feature of estrogen. Estrogen is going to decline. and it starts to decline after the age of 35. So that would be your latter 30s. And so it's more likely that your egg quality after the age of 35 is not going to be as pristine as in your 20s. And then also the likelihood of how often you ovulate is going to decrease. And then the quality of the eggs are also going to decrease. So it's not that it impacts it negatively, it's impacting it the way it should, because that's the biological feature of what your ovaries do. We're born with the amount of eggs that we will ever have when we're babies. And what starts to happen is when we start to have our periods in our teens, our early teens or late, and 9, 10, 11, 12, 13, however old, is then those eggs start to get released. So they just keep releasing over time. And by time we hit our 35 into early 40s, they decrease in their function, quality, and ability to do it consistently. So that is not a negative feature, it's a biological feature of what naturally happens in our body. How do you feel about GLP-1 in conjunction with hormone replacement therapy? So many of my patients with higher BMI, despite working out. Yes. So the higher BMI, let's start with the last part of that statement. Higher BMI is coming because of the changes that I said that occurs with fat, insulin, glucose. So I'll answer it two ways. HRT is going to help give you that buffer back of estrogen, which will then help your insulin and glucose. But the GLP is solely focused on the shuttling of insulin glucose. So, one, you will start to see an indirect kind of appeal with using just HRT and weight, and more of weight management, not weight loss. When you
Mm-hmm.
tap on a GLP-1, you're going to get phenomenal results with weight loss. And that will actually be accentuated if you are also on HRT while using a GLP. So I actually have a lot of patients who are on
Mm-hmm.
both. I have patients who are just on one and or the other, but they understand why the differences are, or they can use them in combination. So they can use it in combination. I think it's a great tool to use both. If all symptoms are due to loss of hormones, why doesn't HRT help relieve some and not all? Great question. So I always like to say that there is menopause and then there's aging, right? So you're going to have some features of symptoms that you
Mm-hmm.
have that come with aging and then some with menopause. So you can be on HRT and it relieves some, if not all, of your features of your symptoms. So there's two reasons why that may happen. One, just maybe an aging process, and the goal with HRT is not to make you feel like you were 20. The goal of HRT is to, in your current state, feel your best.
Mm-hmm.
And so there's another reason why is maybe you're not being titrated high enough on your HRT. Maybe you need to add some more progesterone, bring down some estrogen, add some testosterone. And again, that goes to who is the provider in really knowing how to give HRT. It is not a science, it's an art, because everyone comes in with a different complaint. You have to understand also how to titrate each of the hormones, what modality to give it in. Is it oral? Is it transdermal? Is it pellet? Is it all of these different kinds? And everyone responds to hormone depending on what they take differently. So I could put a patient on a transdermal, increase them to certain percentages of estrogen, and it's just not taking as well as someone who might be on a low level of transdermal and they're doing great, because they all have different absorbencies and everyone experiences it so different. So you have to go to a provider who truly understands how are we going to move you through this process, what works best for you, what we need to take out, what do we need to put in, but also lifestyle changes. Lifestyle changes are one of the biggest
Mm-hmm.
parts of perimenopause. So you have to be willing to understand this is a biological feature of my life, and I need to also adapt to it with the way that I live my life through diet, changing the way I eat, increasing protein, the way I exercise, and decreasing the amount of cardio. Cardio is not bad, but what's going
Mm-hmm.
to really get you where you want to be as far as utilizing glucose is weight training. So all of these little features, it's never just one thing. It's never just one tool thing, and you're going to fix everything with one thing.
And
There's
as
another,
we talked about,
yeah,
sorry, as we said earlier, I mean, some of these symptoms might not be related to menopause, so just be careful about that. And
yeah,
maybe you want to rule out if you're on the highest or the right dose of HRT and you still have
mm-hmm,
those symptoms, then you may want to talk to your healthcare provider
yeah.
and check other possibilities.
Absolutely. Here's a good question. How does perimenopause declining estrogen affect women with estrogen dominance, endometriosis? So, estrogen dominance, that's a term that's used when there may be features of how you respond to estrogen. And if your estrogen receptors either attract or utilize estrogen in different ratios to some other people. Now, there are different forms of estrogen. There are three subtypes of estrogen. One is just usually pregnancy related, but then you have estriol and estradiol, with estradiol being the dominant type of estrogen that you have. And so, again, that it's most people don't have an estrogen dominance type of issue, but they can. But it doesn't necessarily mean that they can't tolerate estrogen in an HRT form. That's something that can be guided very carefully, or utilization more of testosterone, which does have a byproduct of estrogen, and that might be the better form of estrogen that you receive through testosterone. Endometriosis, great question. As a gynecologic surgeon, I used to do a lot of surgery on people with endometriosis and really titrating that estrogen. Typically what you will see, because it's endogenous estrogen that really was the inflammatory part of endometriosis, typically what you will see is that when you put people on HRT, they don't always, you have some who do respond with the pain feature of endometriosis, but most women that I've put on in the late perimenopause, menopausal phase of estrogen may not respond the same way that they used to with the endogenous, meaning coming from the actual organ estrogen that they had earlier in their life. So again, it's something that should be discussed very concretely before you start, but also being willing and open to possibly starting HRT, not being afraid of the estrogen, because estrogen is not just for symptoms, it's for longevity, decreases osteoporosis, dementia, and also what's the other one? Heart health, helps with heart health. So it's not just what HRT is recommended, it's what kind, how much, what dose, and what are you willing to also try. So it really is a very nuanced type of conversation, never just one answer. I wish I had a practice in Canada. That would be awesome. I would summer in Canada, not winter in Canada, and come up and see patients in the summer.
Interestingly enough, or sadly enough, I had
Yeah.
two patients who've been denied having HRT due to endometriosis. I mean, it's very personalized, as you mentioned, and we
Hmm.
have to go each case by
Yeah.
case. But when they came to see me, and I started them on low dose HRT, and they're doing very well.
Yes. And
So,
if you just kind of like side note, if you do, you can DM me if you're in Canada. I
mhm.
have consulted people in Canada. So DM me and we can connect if you are interested in consulting with me. So I do consult people and do consultations all the time. And I have done a handful. I've had people fly down from Canada to see
uh,
me, but
Good
if
to
you
know.
DM me, we will definitely get you hooked up with a way to consult. Is it safe to use vaginal estrogen cream on your face? So the quick answer is yes. There are some companies that compound it and make it into a face friendly type of estradiol or estriol, can be a mix. Usually estriol is what they use
Hmm.
in the face creams, but you can use a vaginal estrogen. I would say use very little and mix it with something else. And then you can use it either every day or maybe 3 times a week. But yeah, it is safe. Would estrogen dominance display as more frequently heavy periods? The answer is not all the time. That doesn't necessarily mean that's how estrogen dominance is displayed. Many things can cause frequent heavy periods, such as thyroid disorders, fibroids, polyps in the uterus, adenomyosis. So there's a lot of other things that can cause more frequent heavy periods than just estrogen dominance. That can be one of the features, but I wouldn't say it's at the top of the list. The most common cause of heavy frequent periods is actually fibroids. So I would probably start with that first, maybe polyps as well. Does spotting between menses in your late 30s affect fertility now or in the future? Spotting between menses doesn't necessarily mean that that's impacting fertility in any way. All it means is that there can be many reasons why you have spotting. It could be you have a vaginal infection, why you're just
Hmm.
spotting. It could be actually more from the vaginal canal than the uterus. It could be because maybe you took birth control pills and then you stopped and now you're kind of coming back onto your real cycle. It can be because you have a polyp. It can be because you are going through a little bit of hormonal shifts that causes the spotting, like we discussed before. So again, a lot of different reasons, but it doesn't necessarily, that is not, I would not make that a direct correlation that because you're spotting, it's affecting your fertility. We have many people who don't have periods and have very infrequent periods who can still get pregnant. We have people who have very heavy periods or spot in between. So it's never just this means this, especially when you're talking about fertility, because there's so many other things that create fertility issues, and it's never just one thing.
A very common question that I receive is about how old is too old or too young to start HRT?
Great question.
Mm.
So, what we are moving away from, before we used to say you have to be confirmed menopausal before starting HRT, we now know that when those symptoms start to happen, whether it's some people start in their late 30s, early 40s, mid 40s, that means they're having shifts in their hormones, which are causing the symptoms. So now, I would not say all, but a lot of providers are now starting to treat their patients in the perimenopausal phase when they have symptoms. It is very safe. There is no reason to say that you cannot start someone, I mean, other than medical issues, but yeah. Do you ever prescribe estradiol injections if transdermal is not working? I know some women who are in. So, estradiol injections, yes. Estrogen and testosterone you can get in the form of injections. Do I typically do that? Personally, no, because I think there's other modalities other than injections, such as pill, patch, there are pellets. What is the other form? Creams.
Mhm.
So most of my patients, I would say, even if I did offer it, probably wouldn't want those injections. And same goes for testosterone. Testosterone has less modalities. Testosterone has injection, it has cream. They have sublingual things.
Mhm.
Not n-
Troches
not
and
very often is that offered because there's like a first liver metabolism, sometimes an issue with that. And then also testosterone can be in pellet form. Most of my patients take it in cream or pellet form. Estradiol, most of my patients, again, this is just from my practice,
mhm.
take it in cream form or patch form, and then some pill as well, and then pellets as well. So injections, just in my practice, is not as popular. If I would say for estrogen, and I have a few on testosterone injections,
Mhm.
um, but they're very well versed in what it is, how to do it. But yes, I don't ever prescribe estrogen injections, testosterone injections, yes. How often should you do blood work to monitor how HRT is affecting cholesterol? Good question. So for testosterone, I typically check it more because testosterone does have an impact on cholesterol. Um, how often should blood work be done? So estrogen and progesterone, there are two reasons why I might check it more frequently. If someone is not getting the results they want, I can check it. Also, when we look at, there was a paper recently sent out that looked at the impact of how much estrogen you're getting through your HRT. So there's always symptoms. Is it resolving the symptom?
Mhm.
And then we're looking at how is it impacting your bone health? And there are different absorbency levels or levels that we would want to get you to in order to impact actual bone health. So that's another reason. So there's different reasons and why you should be checking it often. I'm typically one where I don't like to be like every 3 months you have to get it checked,
Mhm.
because if you're going to be on hormones for the possibly the rest of your life, I don't want that to be the lifestyle that now we're checking your labs all the time. There has to be a moment in which we're allowing you to use the hormones, live, and but we can check it every once in a while for a reason. And so I'm not a fan of just being like anyone who's on hormones should be checking it every 3 months. That's not
Mhm.
the way I practice. There probably are that some, and that's fine too. If you're on perimenopause stage, are there supplements? Yes. Oh, to preserve fertility. Again, fertility is a biological thing. And so I want everyone to understand, yes, we are now in the day and age where there's science and innovation technology that can help when someone has a issue because they're later in life, or even if they're earlier in life and have an issue with fertility, that we can help. But your body is going to naturally get to a point where fertility starts to decline, or the ability to get pregnant naturally will decline. So that's where we have to get really clear with the messaging of, we can help to some degree from medicine and science to get people pregnant, but there also is a very big part of that that has to do with that person's biology and age. Age is something when it comes to fertility that we are not in charge of. We do not have control of. I like to put things in the list of things we can control and the things we can't control. We cannot control age. We cannot control someone's ovarian biology and genetics. And so the goal is when we get to a point in someone's life where they may have a fertility challenge, is for us to step in and saying, these are the things that we can do. Outside of that, I would say the best thing that someone can do is talk to a doctor earlier on in their life to say, where am I, maybe lab wise, to look at my ovarian function and preservation. So I kind of have an idea of where I am, because people will do that curve differently. That's what I'm not in charge of. People are their own people in biology. The other thing that I would say is lifestyle early on in life is so important. So what you do, again, these are the things that you control, is what things do you feed your body? What thing do you exercise?
Very
What is your ability to sustain your body internally in a healthy way so your fertility has a better chance at thriving and being the best it can be because you've provided a great ecosystem for it with the things that you do in lifestyle. And so that would be diet. So it doesn't specific supplement that does it. It's what's your overall health? What's your overall way of sustaining your livelihood in your life so that your fertility has a better chance outside of the uncontrollable things of genetics, aging, and biology. Is HRT? And then this is my last question. This is great. I love
lovely
questions.
questions.
Oh, well,
Yes,
now
great
one other one
questions.
came in, so I'll get that one too. Is HRT recommended with family history and positive cancer? Great question. So family history is different than personal history. So if you have a strong family history of this is where you start to have better conversations on what risk am I willing to take? What is the specific cancer that someone may have had? Who were they to you? And how young were they when they got the cancer? Because those are general questions, because you may not fall into the same category just because of family history at it. I love how all these questions are coming in. Now, if you have a personal history, like you have had estrogen and progesterone positive cancer, that's when we have different discussions on what you can take in the HRT family. There are a few options, but those are the differences between family history, personal history. Is it common to feel lots of bloating when starting the transdermal patch? Yes. Changes in hormones can create a few kind of like onset of things that you're like, oh, this is interesting. The key feature is how long does it last? And is there something else that you can implement in your lifestyle and nutrition and exercise to offset the bloating? But yes, that can happen. Is it possible to improve egg quality in your late 30s? These fertility questions are you can preserve or improve egg quality with as much as you can. There's no direct correlation with like diet and exercise. Again, that's going to your health. Technology wise, the best way to improve egg quality is to do egg retrieval, because then you're extracting the egg at that time at its best time frame when it is for a year, 2 year, 3 years later, because now you have it frozen in time to what it is. So I would say that's the only way to keep egg quality at that time that you have it, maybe in your late 30s, is to do egg freezing. When on HRT, if you bleed, yes. So if you're on HRT and you bleed 2 to 3 days after taking progesterone, is there a reason? Yeah. So the kind of the interplay between estrogen and progesterone. Progesterone is responsible for keeping the lining thin in the uterus, and so if you take it, sometimes it's shedding what estrogen may have put there to make it plump. Estrogen plumps, progesterone sheds. So estrogen may have plumped something, and once you started progesterone, it's allowing that to shed. So that is possible. Is this because of estrogen? Yes. So it's the estrogen builds and bulks and provides tissue in the uterus, and when you take progesterone after, it may shed it. And that's it. Well, I hope
One
this was helpful.
question,
Yeah.
one last question. It was in the question bubble about.
Prolactin to lowering the prolactin. The effect of prolactin. Yes, so high prolactin lives in the world of hormones, so it can impact hormones in general. So impacting HRT, it can impact HRT, but the thing that I would do is just withdraw the HRT to see what's it impacting without HRT. So yes, anytime you have high prolactin, the goal is just to reduce it, whether or not you have HRT or not. So reduce the prolactin and then restart HRT. So the goal
Mhm.
first to be lower the prolactin.
So the last question is
Mm-hmm.
about if there's hormone imbalances in women, this during perimenopause and menopause, be a risk for Alzheimer's disease,
Oh,
dementia.
yeah. So the risk for Alzheimer's disease, there's a great book, The Menopause Brain by Dr. Lisa Mosconi. She also contributed to my book. Everyone go
Uh,
get a copy, Generation M.
Definitely, for
We talk
sure.
about brain health in there, and basically there is a very direct correlation between the decline in estrogen over the course of 40s and 50s that we do start to see an impact on how that impacts brain and plaque and the increase of dementia and Alzheimer's disease. And Alzheimer's disease is seen more likely in women than in men.
Mhm.
And so that there is obviously that thing that we have that men don't have, which is the decrease in estrogen. So yes.
Mhm. Great.
All right. Well, thank you
Lovely. It
so
was
much for having me
amazing.
on.
And I can't
Yes.
wait to meet you in person in
Yeah.
April, early
Yes.
April.
That sounds awesome. I will see you then. Thank you,
Lovely. It
everybody.
was very informative. Thank you very much.
Yes.
And
Everyone go follow me. Everyone go get a
yes,
copy of
we
Generation
will.
M. And then
We
if
will.
if you want a consult, you just DM us and we'll get you set up.
Mhm.
All right.
Great. Lovely. Thanks everyone for being here
Happy
today, joining us.
Friday.
Happy Friday. See you soon.
Okay, bye.
Bye.